Imagine waking up feeling completely normal. You slept well, you walked to work, you climbed the stairs without getting out of breath. There is no pain, no fever, no obvious warning that anything inside your body is going wrong. Then, during a routine blood test, a doctor looks at one number and pauses. Your LDL cholesterol is high. The strange part is that you do not feel anything, and that is not unusual. High cholesterol usually does not announce itself with pain or a visible symptom. A person can have elevated LDL cholesterol for years and still feel perfectly healthy. So the mystery begins with a simple question. How can something that can contribute to serious disease remain almost completely invisible? The answer takes us somewhere unexpected, not to the heart first, but to the walls of the arteries. Inside the body, blood is constantly moving through an enormous network of vessels. Every minute, your heart pushes blood through arteries that carry oxygen and nutrients to tissues throughout the body. When those arteries are healthy, blood can move through them efficiently. But over many years, something can begin to change. Particles carrying cholesterol circulate through the bloodstream. One of the most important is low-density lipoprotein, or LDL. You may have heard LDL called bad cholesterol. That description is useful, but incomplete. LDL is not a poison. The body actually needs cholesterol. It is used to build cell membranes and make important hormones and other substances. The problem is not that cholesterol exists. The problem is what can happen when too much LDL circulates through the bloodstream for too long. And this is where the story becomes much more interesting. Imagine a tiny LDL particle moving through the bloodstream. Most of the time, it is simply part of the body's transport system. But some LDL particles can move into the artery wall. Once there, they can become involved in a chain of biological reactions. The immune system responds. Inflammatory cells arrive. Over time, cholesterol-rich material can accumulate. What began as an invisible change can gradually become atherosclerosis, the buildup of plaque inside arteries. And this process can take years, sometimes decades. There is no sudden moment when a person wakes up and realizes that plaque has started forming. That is one reason cholesterol is so difficult to understand. The danger is not usually immediate. It is cumulative. A single high cholesterol reading does not tell us exactly what will happen to one individual. But decades of research have shown that higher LDL exposure is associated with greater risk of atherosclerotic cardiovascular disease. And the longer the exposure continues, the more important the cumulative burden becomes. This creates a strange contradiction. The thing you can measure easily is a blood number. The thing you cannot easily feel is what may be happening inside the arteries. And those two realities can exist at the same time. A person can feel healthy while their cardiovascular risk is quietly changing. But there is another question. Why does one person have high LDL while another person, eating a similar diet and living a similar lifestyle, does not? This is where genetics enters the investigation. Cholesterol is not controlled by food alone. Our genes influence how the liver produces, processes, and removes cholesterol from the bloodstream. Some people inherit genetic variants that cause unusually high LDL levels. In conditions such as familial hypercholesterolemia, LDL can remain extremely elevated from a young age. And because the condition may have few or no obvious symptoms, people can live with it without knowing. Sometimes the first clue is not a blood test. It is a heart attack occurring earlier than expected, or a family history of premature cardiovascular disease. This is one reason doctors sometimes look beyond a single cholesterol number. Family history can reveal information that a laboratory result cannot. But genetics is only part of the story. Age matters. As people get older, cholesterol patterns can change. Hormonal changes can influence lipid levels. Body composition can change. Physical activity may decline. Metabolic health can change, and conditions such as diabetes can alter cardiovascular risk in ways that cannot be explained by LDL alone. This is why two people with the same LDL number do not necessarily have exactly the same overall cardiovascular risk. The number is important, but it exists inside a larger biological picture, and that larger picture is where cholesterol becomes confusing. Consider someone with an LDL level that is considered elevated. They may look fit, they may exercise regularly, they may have a healthy body weight, they may never smoke. Does that mean the LDL number does not matter? Not necessarily. Likewise, someone with obesity or diabetes may have a much higher overall cardiovascular risk, even if their LDL is not dramatically elevated. The body does not operate according to one number. Doctors therefore consider multiple factors when estimating cardiovascular risk: blood pressure, diabetes, smoking, age, family history, cholesterol levels, and other medical conditions. The goal is not to label one number as good or bad in isolation. It is to understand what that number means in context. But there is something even more important hiding beneath this idea. For a long time, scientists debated how much LDL actually matters. Was it simply associated with heart disease? Or was it one of the biological causes of atherosclerosis? Over decades, evidence accumulated from several different directions. Population studies found relationships between LDL levels and cardiovascular events. Genetic studies found that people naturally exposed to higher or lower LDL throughout life can have substantially different cardiovascular risks. And clinical trials showed that lowering LDL with certain treatments can reduce the risk of cardiovascular events in appropriate patients. Taken together, these lines of evidence have made one conclusion increasingly strong. LDL is not merely a passive marker of cardiovascular risk. It plays a causal role in atherosclerotic disease. But even that statement needs context. It does not mean every person with high LDL will develop heart disease. It does not mean someone with low LDL can never have a heart attack. And it certainly does not mean cholesterol is the only factor that matters. Cardiovascular disease is a complex process involving blood vessels, inflammation, blood pressure, metabolism, genetics, smoking, age, and many other factors. LDL is one major piece of the puzzle, not the entire puzzle. And this distinction matters because cholesterol has become one of the most misunderstood numbers in modern medicine. Some people fear it, others dismiss it. Some believe that if they feel healthy, their cholesterol cannot be dangerous. Others assume that any cholesterol level above a certain number means disease is already present. Neither view tells the whole story. The reality is more subtle. High LDL does not mean that a person currently has a blocked artery. It means the conditions associated with artery disease may be more favorable to developing over time. That difference between risk and disease is critical. Risk is about probability. Disease is what has actually happened. And sometimes, the distance between the two can span decades. That is why a cholesterol test can feel almost strangely disconnected from everyday life. You look at the number, you feel normal, nothing hurts, nothing looks different. But the number may be telling a story about long-term exposure that your body has not yet made obvious. And now we reach the question that makes this investigation even more complicated. If LDL can contribute to artery disease over many years, why do cholesterol levels vary so dramatically between people who appear to live similar lives? Why can one person eat a relatively ordinary diet and have high LDL? Why can another person eat poorly for years without seeing the same blood test? And how much of the difference comes from genes, metabolism, age, body weight, diabetes, hormones, or the way the liver handles cholesterol? To answer that, we need to move deeper into the system. Because cholesterol is not simply something you eat. Much of the cholesterol circulating in your blood is made by your own body, and the organ controlling much of that process is one of the most important players in this entire story: the liver. In the next chapter, we follow cholesterol from the bloodstream into the liver and then back into the arteries to understand why some people accumulate more LDL, why risk can remain hidden for years, and why the same cholesterol number can mean very different things in different people. Chapter 2: When the number becomes a warning. The liver changes the way we think about cholesterol. Because cholesterol is not simply something that arrives on a plate, your body makes it. The liver plays a central role in regulating how much cholesterol circulates through the bloodstream, including how LDL particles are removed. One of the most important mechanisms involves LDL receptors. Think of them as microscopic docking stations. They help the liver pull LDL particles out of the blood. When this system works efficiently, LDL can be cleared from circulation. But when the system is altered by genetics, metabolic conditions, medications, or other biological factors, LDL can remain in the bloodstream for longer, and that is where exposure begins to matter. The bloodstream is not simply carrying a number, it is carrying millions of particles. Some can eventually enter the artery wall. The immune system can respond. Inflammation can develop. Cholesterol can accumulate. Over years, plaque may grow. At first, the artery may continue functioning normally. The person may feel completely fine. Even as the process progresses, there may be no warning pain. This is one reason atherosclerosis is sometimes described as a silent disease. The first obvious sign can be a major cardiovascular event, a heart attack, a stroke, or another complication caused by an artery becoming severely narrowed or a plaque suddenly rupturing and triggering a blood clot. But this does not mean every person with high cholesterol is secretly developing a dangerous blockage. That would be an exaggeration. A blood test measures risk-related biology. It does not provide a direct picture of every artery in the body. And that distinction is important, because one of the biggest mistakes in conversations about cholesterol is treating a laboratory value as if it were a diagnosis. It is not. Instead, cholesterol becomes meaningful when placed inside a much larger picture. Consider two people. Both have elevated LDL. One is young, has a strong family history of early heart disease, and has likely had high LDL for decades. The other is older, has recently developed a moderate increase in LDL, but has no major additional risk factors. Their numbers might look similar. Their biological histories may not be. This is why doctors consider duration of exposure, age, family history, blood pressure, diabetes, smoking, and other factors when evaluating cardiovascular risk. The same number can sit inside very different stories, and genetics can make those stories dramatically different. Familial hypercholesterolemia is one of the clearest examples. People with this inherited condition can have very high LDL from an early age because the body's ability to remove LDL from the blood is impaired. Someone may feel perfectly healthy through childhood and young adulthood, but years of unusually high LDL exposure can increase the likelihood of developing cardiovascular disease earlier than expected. This is one reason family history can be so revealing. If close relatives have experienced heart attacks or other cardiovascular disease at unusually young ages, that information can change how doctors interpret a cholesterol result. But genetics does not explain most high cholesterol. For many people, the picture is a combination of inherited biology and environment. Diet can influence cholesterol levels. So can body weight, physical activity, alcohol intake, certain medical conditions, and some medications. But even here, the story is not as simple as eat this food and your cholesterol rises. Different people respond differently to the same dietary pattern. Their genetics differ, their metabolism differs, their gut environment differs, their liver handles lipids differently, and their overall health can change the result. This is why population studies are so important. Researchers cannot understand cholesterol simply by looking at one person. They need to observe patterns across thousands or millions of people. Over decades, those patterns have revealed something remarkably consistent. Higher LDL exposure is linked to a greater risk of atherosclerotic cardiovascular disease, and lowering LDL can reduce cardiovascular events in people for whom treatment is appropriate. This evidence comes from multiple types of research rather than one single experiment. That matters. When different scientific methods point toward the same biological conclusion, confidence becomes stronger. But then another controversy appears. If LDL is so important, why do some people with apparently normal cholesterol still suffer heart attacks? Because cardiovascular disease is not caused by LDL alone. Blood pressure matters, smoking matters, diabetes matters, inflammation matters, age matters, genetics matters, and other blood lipids and biological processes can contribute as well. A person can therefore have a heart attack without having what people commonly think of as high cholesterol. That does not make LDL irrelevant. It shows that cardiovascular disease has multiple pathways, and this is where cholesterol becomes a story about probability rather than certainty. A risk factor increases the likelihood of an outcome. It does not guarantee the outcome. That distinction can feel unsatisfying. We naturally want medicine to give us simple answers, safe or dangerous, normal or abnormal, good or bad. But biology rarely works that way. Now consider another question. Why do some people discover high cholesterol only after they develop another health problem? Sometimes the answer is metabolic health. Insulin resistance, diabetes, obesity, and other metabolic changes can affect lipid patterns and cardiovascular risk. A person may have changes in blood sugar, blood pressure, body fat distribution, and cholesterol occurring at the same time. These conditions can reinforce one another. But once again, correlation does not mean every one of these conditions directly causes every other one. The human body is an interconnected system. That is precisely what makes the investigation difficult. And it also explains why feeling healthy is such an unreliable test. You cannot feel LDL moving through your bloodstream. You cannot feel a small plaque developing inside an artery. You cannot reliably detect changes in cardiovascular risk by how energetic you feel on a particular morning. Symptoms usually appear when disease has progressed enough to interfere with normal function. By then, the underlying process may have been developing for years. That does not mean people should live in fear. It means silent risk factors are one reason preventive medicine exists. Blood pressure can be measured, cholesterol can be measured, blood glucose can be measured, family history can be discussed, and these pieces can be combined to estimate risk before a major event occurs. This is one of the remarkable shifts in modern medicine. Instead of waiting for disease to announce itself, doctors can sometimes identify biological risk long before the first symptom. But there is another reason cholesterol remains controversial. What happens when doctors lower LDL? The evidence from randomized clinical trials has generally shown that reducing LDL lowers the risk of major cardiovascular events, particularly in people at sufficiently elevated risk. The exact approach depends on the person's circumstances. Some people may benefit from lifestyle changes. Some may require medication. Some need both. And the choice is not something a person should make from a single internet video. The appropriate treatment depends on the individual's risk profile, medical history, other conditions, possible benefits, and potential harms. This is where good medical science avoids extremes. Cholesterol-lowering treatment is neither something everyone automatically needs, nor something that should automatically be feared. It is a medical decision based on evidence and individual risk. And there is a deeper lesson here. The goal is not necessarily to make one laboratory number look perfect. The goal is to reduce the likelihood of cardiovascular disease while considering the whole person. That distinction becomes especially important as people age. Because cardiovascular risk does not suddenly appear at one specific birthday, it accumulates. Years of exposure to LDL, blood pressure, smoking, diabetes, and other factors can gradually change the condition of the arteries. This is why prevention can matter long before symptoms appear. But science still has unanswered questions. Researchers continue to investigate why some plaques become unstable, while others remain relatively quiet. They are studying inflammation inside plaques. They are investigating differences between LDL particles and other lipid-related markers. They are learning more about genetic differences that influence cardiovascular risk. And they are examining why some people develop disease despite having relatively modest traditional risk factors. The science is becoming more precise, but it is not becoming simpler, and perhaps that is the most honest conclusion of this investigation. High cholesterol is not a disease you can reliably feel. It is a biological signal that can reveal something about long-term cardiovascular risk. LDL is necessary for normal biology, but excessive exposure can contribute to atherosclerosis. Genetics can strongly influence cholesterol, so can age, metabolism, diet, body composition, and other factors. And the consequences often develop slowly, sometimes over decades. The person who feels healthy today may genuinely be healthy today, but feeling healthy does not tell us what every blood vessel looks like. That is why a cholesterol test can be so valuable. Not because a number can predict the future with certainty, but because it can reveal information that the body's symptoms may not. And there is something hopeful about that. A silent risk factor is not necessarily an invisible problem forever. It can be measured, it can be interpreted, and when elevated risk is identified, there are evidence-based ways for healthcare professionals to reduce cardiovascular risk in appropriate patients. The mystery was never really why people with high cholesterol do not feel sick. The deeper mystery was how much can happen inside the arteries before the body finally gives a warning. Science now has a much clearer answer. Often the process is slow, often it is silent, and often it can be influenced long before the first major cardiovascular event. So if a blood test ever reveals high cholesterol, the most important question is not simply, is this number high? It is, what does this number mean for this person, over this person's lifetime? That is where medicine moves beyond a single number, and toward prevention, context, and informed decisions. For anyone concerned about cholesterol, cardiovascular risk, or the meaning of a personal blood test, the right next step is discussion with a qualified healthcare professional who can interpret the result alongside individual medical history and risk factors. Because cholesterol may be invisible, but the information it provides does not have to be.